Well, I'm going to be talking to you today about some of our work on the complex relationship between HIV and nutrition. Now, HIV is worse than terrible, and that's not news. We've been hearing about the devastation of HIV and AIDS for years and even decades. In fact, we even know how to treat and prevent HIV. In adults, the primary strategy is safe sex. In infants, through the use of medications such as nevirapine, through safer deliveries and safe infant feeding practices, we can reduce the risk of vertical transmission, which is a transmission of the disease from mother to child, to less than 2%. And in fact, we even know how to manage the disease in many places like the United States. HIV has become a chronic disease rather than the sort of one-year death sentence that we often think of it as. And yet, there are 33 million people living with HIV right now. Why is that? Why is one child infected with HIV every minute and a half? And why, last year, did 1.7 million people die of HIV and AIDS? Given what I showed you on the last slide, about HIV treatment and prevention, these questions remain really very difficult to answer. And it's not to say that progress hasn't been made, because it has by many players in the field of HIV research, by activists such as these, I think it's only men, in Pakistan who are imploring the World Bank to restore funding, by policymakers such as Michel Sidibé, who's the executive director of UNAIDS, by scientists, clinical and bench scientists who are working on great technology to detect and treat HIV, and by frontline workers like this woman in Mozambique who's testing somebody for HIV, and these frontline workers are doing the majority of the care and treatment of HIV. And so without their work, we wouldn't be able to talk about the elimination of HIV, which is something that has now started to be whispered in certain corridors of science and policy. But despite this work, these questions still stand, such that we have to conclude that our current approaches are necessary but not sufficient. And we think that one angle in particular has been overlooked. We think that the role of nutrition has been overlooked. And therefore, this is the focus of my research group. Nutrition has, because it's been overlooked, we're really trying to hone in on that. And in fact, nutrition has a long history of being an overlooked or hidden culprit in disease. And I'll just take two of many examples. And the first is pellagra. So pellagra comes from Italian for rough or sour skin. And pellagra is a micronutrient deficiency. It's caused by a deficiency of niacin. But it used to be called Asturian leprosy because it was thought to be an infectious disease until the 1930s, when a doctor did what would now be an extremely inappropriate experiment on prisoners, that if they did this experiment, they could go free, and found that a diet heavy in corn that hadn't been soaked in an alkaline solution caused pellagra. So no longer an infectious disease, it was a micronutrient problem. And similarly, this is a second example that emerges from our work from our very own faculty members here at Cornell. David Pelletier, Ed Frangillo, and Jean-Pierre Habicht worked to identify the underlying causes of death in under 5. So this is a plot of children, of the causes of death of children under 5. And you can see 19% were caused by diarrhea, and 19% of the deaths under 5 were caused by acute respiratory infections. But what they did is, using some sophisticated epidemiologic techniques, is to elucidate that, in fact, if those children hadn't been malnourished when they got a cold or pneumonia or diarrhea, that they wouldn't have died. So my point is that there's a precedent for nutrition being a really important part of disease causation. So let's go back to nutrition and HIV. This is a map of the prevalence of HIV, where the darker the color, the higher the prevalence. So in this very darkest tip of Africa, the prevalence, which is like in Botswana and South Africa, is between 15 and 28% in the country. And this is a prevalence of undernourishment, where again, the darker the color, the higher the prevalence. And what you'll observe is that in sub-Saharan Africa, there's some of the highest prevalences of HIV and undernourishment. And so we can call these overlapping epidemics syndemic. And syndemic simply refers to diseases that have a biological interaction in which one exacerbates the other. So our approach, in which we consider the two epidemics simultaneously, differs from the traditional biomedical approach that regards them as sort of existing in parallel. So bearing the syndemicity in mind, I'm going to give you just two more background slides on how these epidemics pertain to specifically maternal and child health. So HIV hits hard at every stage of life, especially in sub-Saharan Africa. It affects women of reproductive age. It has consequences during pregnancy, lactation, and childhood. So of the 33 million people in the world who have HIV, 2/3 of them live in sub-Saharan Africa. And there, 60% of women are infected. 60% of the population are women, which really contrasts to other places where HIV is primarily a male disease. And because of this burden of disease in women in Africa, HIV is a leading cause of death of reproductive age women worldwide. And in 8 African countries, for example, the median prevalence in antenatal clinics was greater than 15%, and as you can imagine, that has real consequences for transmission. As you saw earlier, there were 370,000 pediatric infections last year, which has resulted in about 2 million children living with HIV/AIDS. And we don't know how many millions of HIV-exposed but uninfected children. And HIV-exposed children face a number of health risks not experienced by children who haven't been exposed whatsoever. So in the same way that you saw that HIV disproportionately affects women and children in sub-Saharan Africa, so do problems of nutrition. And here, there are just two terms I want to clarify for you: food insecurity versus undernutrition. So food insecurity refers to irregular availability, access, or use of food. And undernutrition is sort of the manifestation of not having regular intake of food. There are about 2 billion people who are considered food insecure in the world, about 800 million people who are considered undernourished. So it's no surprise that moms and their capacities are the major determinants of maternal and child health, and that there are gender biases in food and income generating activities. And even once that food or income has been generated, who gets to control what's done with that food or income there's also a lot of gender biases. At the same time that there are these constraints, there's increased nutrient demands because of the caloric requirements of pregnancy and lactation, and a less ability to obtain and prepare food because of either physical, like, oh, I can't bend over, or social prescriptions, like you can't go into the fields when you're pregnant. So poignantly, there's greater needs at the same time that there's less access. So our core question, and this is our group, hot off the press this morning, we took this picture, is what is the role of nutrition in adverse health outcomes among HIV-positive women and their infants? So we're asked to talk about what methods we use. I'll just give a brief overview. So to attack this overarching question, I draw on training that I've had as a medical anthropologist, that's what I have my master's in, and a public health nutritionist. And the first is the qualitative and ethnographic stuff, scientifically put. So this is a focus group discussion in Tanzania that we conducted with healthcare workers and HIV-positive moms who had participated in our study of breast milk pasteurization to reduce transmission of HIV. But we also do population-based surveys. So there's a very large epidemiologic study we did in Zanzibar, Tanzania, of pica. Does everyone know what pica is? It's cravings for non-food substances. I'd be happy to talk about that at another time. So lots of people, especially during pregnancy, eat earth and raw starch. And this was a very large survey to study that. We also do a lot of anthropometry and biomarkers. So here we're doing some training on how to weigh children, dried blood spots, and other micronutrient kind of assays. So we were also asked to present a few findings to date. And although we do work in all of these areas, I'm just going to focus on prevention in infants. And I'm going to talk about 3 studies that are going on right now in sub-Saharan Africa, 2 of which are in Uganda and 1 in Mozambique. So the first one is in Tororo, Uganda, and it's called Promote PIs. And it's a clinical trial where we're comparing 2 different antiretroviral therapy regimens among HIV-infected pregnant women and then their infants. And the primary outcome of the study is actually malaria, for reasons won't get into. But what we've observed is there are a lot of major nutritional problems that these women are experiencing. And one of which, so I was happy to be at the University of California, San Francisco when this study was starting and they were needing a nutritionist. So one of the things that we observed is grossly inadequate gestational weight gain. So I don't expect this to, the actual amount to mean something to you, so let me put it into context. So women were gaining a median of 0.4 pounds per week in the second and third trimester. And to put that in context, what's recommended in the United States for a woman of normal weight is a pound a week in the second and third trimester. And even more disturbingly, sort of more poignantly, between enrollment, so women are enrolling in the study somewhere around the 5th month of pregnancy. So between the 5th month of pregnancy and the 9th month of pregnancy, 15% of these women actually lost weight. And unsurprisingly, low gestational weight gain was associated with a much greater odds of low birth weight and preterm delivery, which has major health consequences for the infants. So we also looked at food insecurity, and it was extremely high. We used the FANTAS assessment tool called the Household Food Insecurity Access Score Survey, HFIAS. And we did it in the period of the most food secure time of the year. And what we found was that 77% of these mothers were severely food insecure. So this was in sort of 2010, early 2011. We thought, we need to do something about this. And so what we did is we thought, well, how can we increase the intake of these moms who are in our study? And so we did a formative study with local, so this is peanut butter, this ground nuts as they're called, big milled and dried fish from Lake Victoria, as well as imported supplements as ready-use therapeutic food and micronutrient sprinkles. And then in 2012, we did what I think is the first macronutrient supplementation study among HIV-infected pregnant women. And as much as I'd like to share those data with you, the study just concluded, so next time I see you, I'll let you know just how much weight they gained and how much they liked or disliked the supplementation. But it's also important to acknowledge our funders for this. So the second study is a study in Mozambique, and it's one of the inaugural projects of the Cornell Care Impact Through Innovation Fund that Frank mentioned at the beginning of this session. So it's called Começando Saudável, which means starting out healthy. And this is an intervention study using performance-based incentives to improve retention in what I'll explain to be what is known as a cascade. And this project is headed up by Roseanne Schuster, who's a graduate student here in nutrition, and it's implemented with some really wonderful care staff in Mozambique. So in order for the risk of vertical transmission to be reduced to the 2% that I mentioned at the beginning of this study, each step in this cascade has to happen. So in sub-Saharan Africa, the primary way for pregnant women to receive HIV services is at the antenatal clinic. So women have to attend the clinic. They need to be offered an HIV test at the clinic. Those kits can't be stocked out. They need to agree to take the test. They need to get the results, which sometimes happen immediately, sometimes don't happen for 2 or 3 or 4 weeks. And then those results need to be properly interpreted. Drugs need to be offered to her if they're available. She needs to accept to take the drugs. And then once she has the drug, she needs to swallow the pills. And usually this, the prescription, the amount of pills are given for about 30 days. That means she needs to come back to the clinic every 30 days, and so on and so on and so forth. So this is, it's not surprising that there's a lot of drop-off in this cascade, but just as a sort of thought experiment, even if 90% of women make it to each step, that means by the end, with 9 steps, that only 39% of the women make it all the way through the cascade. And I can tell you 90% of the women are not making that each step. So we have our work cut out for us. And where Roseanne and the team are innovating is by bringing in 4 cadre of healthcare workers. So not just the nurses and the doctors at the clinic, but also traditional birth attendants, volunteers who are called activistas, and community health workers. And so this intervention, we've been doing the formative work for this, figuring out what the barriers and the promoters are of staying in the cascade. And in this summer, we're going to be implementing this intervention. Thanks again, Atkinson. And our third study is in Gulu, Uganda. And this is in the north of Uganda, which has sort of horrible, and maybe you've heard of this area because of the terrible things that happened with the Lord's Resistance Army there. It's called the PRENAPS, which is short for Prenatal Nutrition and Psychosocial Health Outcomes. And this is a longitudinal study among 300 HIV-infected and uninfected women in northern Uganda. And Barnabas and Angela, who are implementing this, Barnabas is a nutrition graduate student here, and Angela Arbach is a medical student at Weill who's taken the year off to do research. They put together a really great website on this study that I would encourage you to visit. And we're seeing both high food insecurity and a lot of maternal depression, and these things seem to be strongly correlated. But again, we're just in the process of enrollment, so I don't have lots of data to share with you on it. But the results are so sort of striking that we thought it's worth following these women sort of beyond just delivery. So we have submitted funding for application for funding for post-naps, which will follow babies until they're about 6 months old. And we thank Tufts and USAID through their Nutrition Collaborative Research Support Program for making that study happen. So, looking to the future, which is something else we were asked to talk about, I have a study in the works called PED-Moromo, which is Luo, which is the language spoken in Nyanza province, Kenya, also on Lake Victoria. And that means enough feeding. So as you saw, there's a various of components of nutrition in the previous studies, but none have brought together the sort of longitudinal measurements of food insecurity and malnutrition, the biological outcomes and child outcomes, together in the context of the social and structural determinants of food insecurity. And that's what we're trying to do here. So what we're trying to do is sort of really focus on the arrows. So what are the determinants of food and nutrition insecurity? How is it that food insecurity affects the mother and the mother's health? And how, in turn, does this affect the infant's health? And it's a 5-year study in which the formative phase should be starting this fall. And then we'll begin the cohort in next year, which will get, I think we said 400 pregnant, HIV-infected, and uninfected women, and follow them longitudinally until their infants are a year old. And then in the third phase, we'll figure out the perfect intervention that will save the world and implement it broadly. And I'm very grateful to the National Institutes of Mental Health for thinking this is worth 5 years of my time. So you've now seen some of the manifestations of our core question. But I don't want you to walk out of the room saying, oh, Sera's doing great stuff on nutrition and HIV, boss. Or maybe you won't even be saying that. But I don't want you to be thinking about me and my work with this. What I want you to do is to apply sort of these questions and think about this to what you're working on. So therefore, on my last slide, I outlined some of the links of HIV to other problems of sustainability that I think some of you are probably working on. So we've seen that HIV has major consequences for health. It also has major consequences for social stability, both because of the havoc, the stigma of HIV, but also the death and migration that's associated with HIV, as well as the burdens on social networks that HIV can cause. But also has major consequences for economic development. There's the immediate costs of care and treatment and funerals associated with HIV, but also there's the sort of long-term effects of school dropouts and a loss of governmental investments on infrastructure, training, when people who are at the prime of their life are dying. But there's also consequences for environmental conditions, so if people are just trying to hold on, they're not thinking about soil integrity or fishing sustainably. They're just trying to survive. And so you see a lot of environmental degradation with HIV. But at the same time, all of these, what we could call consequences of HIV, also make HIV/AIDS acquisition and disease progression more likely. So for example, poor health makes you susceptible to other diseases, and a lack of social support and economic and poverty increase risky behaviors such as transactional sex or concurrent partnership. And even reduced environmental conditions, or environmental scarcity as it was termed, has been associated with, what do I call it? That this environmental scarcity was predictive of risky behaviors such as unprotected sex. And this was in Haiti and also around Lake Victoria. So with that, I'll invite you to chew on our possible links and acknowledge the many people who made this work possible. And certainly this isn't a solitary endeavor, and it's not free. So I'd like to acknowledge my colleagues here at Cornell, as well as those at Makerere University and UCSF, the Cara Cornell collaboration, the PreNAPS team, and the sort of budding team of PeedMoromo in Kenya. And last but not least, I'd like to thank all the mothers and children and their families and mine who made this research possible. So with that, I'll encourage you to be in touch with any questions or further discussion about this work. Thanks a lot.